Welcome back from break, everyone. I hope you had a nice snack or a glass of water and enjoyed Sherry's chair yoga session. And it looked pretty great. Today we have Dr. Roy Lin joining us. Dr. Roy Lin is the director of CurePSP Center of Care at Baylor College of Medicine. He completed his movement disorders fellowship at Columbia University and neurology residency at the Mount Sinai Hospital in New York City. Dr. Lin's dual training in both movement and cognitive disorders position him to specialize in assessing and caring for people at the intersection of these two fields, movement disorders and cognitive disorders. And this is with a keen eye on atypical Parkinsonian disorders. Dr. Lin's research focuses on studying the cerebellum's pivotal role in cognitive and behavioral function of neurodegenerative disorders, which contributes valuable insights to our field. So I'll hand it over to you now, Roy.
Thank you so much, Courtney, for the wonderful introduction. And thank you, everyone, for being part of the Virtual Care Conference. It's my great pleasure to be here today talking about apathy in atypical Parkinsonian disorders, including PSP, CBD, and MSA. Without further ado, let's begin. And I don't have anything to disclose. So the learning objectives today include 3 points. The first one is that I hope through today's talk, I can help you understand how apathy develops in atypical Parkinsonian disorders. Especially, we're going to talk about the brain structure and function change in PSP, CBD, and MSA. How is that related to the apathy? Then we're going to talk about how to recognize the importance of the early detection and assessment of apathy, why it is important to recognize apathy and try our best to treat it. What's the importance of that? And together with this, we're going to explore together the current and emerging treatment options for apathy. So to me, the 3 learning objectives, here are the outlines of my talk today. We're going to spend some time talking about the fundamental knowledge of PSP, CBD, and MSA, again, with a focus on how the brain structure change in relationship with the apathy development. Then, of course, we want to talk about the definition of the apathy and its clinical characteristics. Especially, we're going to talk about how to tell apathy from depression. They do have similarity, but they can also be very different from each other. Then we'll get into the specific disorder, talking about apathy in PSP versus CBD versus MSA. And at the end of the talk, we'll talk about the treatment of the apathy, including pharmacological and non-pharmacological management. So let's begin with the 3 different atypical Parkinsonian disorders. So we know that there is an umbrella term called Parkinsonism, which includes the constellation of symptoms ranging from slowness of the movement, tremor, stiffness, and imbalance or postural instability. So under this umbrella term, majority of people actually have Parkinson's disease, but on the other category, there is an atypical Parkinsonian disorders that include PSP, CBD, MSA, and DLB. So although PSP and CBD and MSA all belong to atypical Parkinsonian disorders, they all have specific features. For example, PSP, the typical Richardson type would have a impaired downward gaze, the eye movement abnormality, and the facial dystonia, overall showing up as what we call startle look. In people with cortical basal degeneration, the classic pattern is that the brain would have very asymmetric change. And all the way down to the pathology level, that both CBD and PSP belong to tauopathy, but their tau distribution pattern could also look very different. So have you ever wondered what does the S stand for in PSP? The S actually stands for supranuclear. So what does that mean? The brainstem is a region that contains a lot of nuclei that is important for our vitals and other function of life. the supranuclear means that the primary pathophysiology of the PSP actually coming from the midbrain and above, including the frontal lobe that is related to the apathy. Likewise, for cortical basal, the cortical actually means the different different area of the surface of the brain we call cortex. That includes the frontal lobe, parietal lobe, temporal lobe, and occipital lobe. In cortical basal, the frontal, parietal, and temporal are the major lobes that got affected. The word basal actually means basal ganglia, which is a deep area that is related to the dopamine signal processing. And the dysregulation of the dopamine can lead to the Parkinson's. So here I want to introduce a important concept. Many of you may have heard about the term frontotemporal dementia, especially behavioral variant of the frontotemporal dementia. It used to be thought as a single disease, but the current contemporary concept is that it's a syndrome. So under this syndrome, majority of the cases actually have frontotemporal lobar degeneration at the pathology level. And all the way down, as you can see from this figure, both PSP and CBD belongs to the FTLD tauopathy. The abnormal protein found in the brain is called tau. So of course, CBD and PSP could actually present with behavioral variant of frontotemporal dementia symptom that includes apathy. So how does that look like in MSA? Here's a classic picture for people with MSA. As you can see, there is a very remarkable neck bending. And if you feel the neck muscle is actually very tight, this is what we call enterocollis, resulting from neck dystonia. But not every MSA patient would demonstrate these features. On the MRI, perhaps the most famous feature is what we call hot cross bond sign. And another important concept is that in MSA, the cerebellum is another brain region that could get affected. As you can see from the MRI, the cerebellum has a very remarkable atrophy. So compared to PSP and CBD, the chief pathology in MSA is actually not tauopathy, it is synucleinopathy. And the core features of the MSA includes autonomic dysfunction, Parkinsonism, and of course, cerebellar ataxia resulting from the cerebellar atrophy. So how does apathy happen in these atypical Parkinsonian disorders? Here, the very important concept for you to know is that apathy is primarily driven by the frontal lobe dysfunction. As you can see from the figure, apathy itself, based on the cognitive processing, actually contains three domains. The first one is the planning difficulty. Apathy means lack of motivation. So to do a thing, we need to have enough motivation, enough planning. So the first part of the brain area that goes wrong is the dorsolateral prefrontal cortex, which means the upper and outer part of the frontal lobe. The second cognitive component that is dysregulated in apathy is what we call initiation difficulty, which is related to the abnormality in the dorsal medial prefrontal cortex, which means the upper and inner part of the frontal lobe. And the third component of the apathy is by name, lack of motivation. So this part is controlled by the ventral medial prefrontal cortex, the lower inner part of the frontal lobe. So regardless, apathy is primarily driven by the frontal lobe dysfunction. With the understanding of that, let's talk about the definition and clinical characteristics of the apathy. So how do we define apathy? Apathy means a person who loses interest, motivation, and enthusiasm about things. On the other end, the person can also lose concerns about what is happening or happening around them. So basically, A lot of times what we hear from the patient and family is that they feel they don't care about anything. So what are the signs? The signs that the person with apathy might demonstrate not having as much of an emotional response to both good and bad events. They do not show curiosity or share new ideas about what is happening around them. And they also find it hard to start and complete a task. Remember the motivation to do things. So the frontal lobe is also related to what we call executive function, how to make a thing happen. So people with apathy can also find it hard to start and complete a task. And overall, they have little interest or energy about things around them. So this is one of the scale that clinicians use to evaluate apathy. We call apathy evaluation scale. To show you this scale is not to guide you how to rate apathy, is to show you what's contained to help you understand more about the symptoms. As you can see what I highlighted here, people with apathy could demonstrate lack of interest in learning new things. They would put little efforts into anything. They don't really approach life with intensity. They have less concern about his or her problems. Overall has low initiative and low motivation. So how does that look like when comparing with depression? So from this table, we know that depression and apathy, they share common features. For example, both a person with depression and a person with apathy could actually have a reduced interest in activities. They might feel fatigue or hypersomnia, sleep all the time, and they don't really have good insight about the symptoms. However, people with depression tend to have more negative symptoms. For example, they tend to feel more guilty about themselves. They tend to do self-criticism. And on the extreme, they actually have higher risk of developing suicidal ideation. People with apathy typically don't really have these negative symptoms. Here is another table to show you the difference between the apathy and depression. Overall, in addition to what we just mentioned on the depression side with more negative impact, negative symptoms, people with depression, actually overall, if it's a neurodegenerative disorder, the degree of the depression can actually get better when the disease progresses. However, if it's a neurodegenerative disorders, including PSP, CBD, and MSA, the apathy severity could increase over time when disease progresses. Clinician, when seeing patient, a lot of times we can actually feel sadness or despair for people with depression. And when treating with antidepressant, people with depression can respond to antidepressant, but people with apathy won't really have good response to that. This slide could be a little bit difficult, but I just want to show you that in addition to clinical symptom difference, all the way down to the neural and anatomical level in terms of brain structure, people with apathy actually have different findings than people with depression, including what we call cortical thickness, the thickness of the surface of the brain. We can see that people with apathy actually demonstrate reduced cortical thickness in the frontal lobe. White matter network. White matter means the nerve fiber under the surface of the brain. People with apathy actually demonstrate larger volumes of the frontal white matter hyperintensities, the white matter abnormality. There's a brain structure called hippocampus, which is an important structure related to memory storage. And as we just mentioned, apathy is a very important and common features in people with neurodegenerative dementia. So not surprisingly, people with apathy actually correlate, the degree of the apathy actually correlate with the lower hippocampal volume. So overall, apathy and depression are distinct neuropsychiatric syndromes based on the diverse presentation of the clinical picture, neuropathological features, and their difference in response to treatment. So why is it important to detect apathy? because the prevalence is actually pretty high. From the combination of data, people with PSP could actually, the prevalence of the apathy could actually be high as 90% from the frontal lobe dysfunction. In people with cortical basal degeneration, the apathy prevalence is 40% or higher. On the clinician side, there are proposed diagnostic criteria for apathy with different kinds of scale. And the caveat is that on the family and patient side, based on what we just discussed for the clinical features, it is important to detect apathy and report it to clinician, and we'll figure out the treatment together. Even more importantly, apathy actually can predict survival. As you can see from this article published in our top journal, Neurology, people with PSP and CBD actually both have higher level of the apathy compared to healthy controls. Compared to other factors that is important for survival, including age at assessment, sex, and global cognitive dysfunction, apathy was found to be the only one that can predict survival. And this study finding overall tell clinician and patient and family that we need a more effective and targeted treatment for apathy. So how does apathy look like in separate atypical Parkinsonian disorders? Let's talk about each of them. From the systematic review of the apathy and depression in PSP, we know that both depression and apathy, the prevalence are actually both high in people with PSP. And here is an interesting study from Mayo Clinic. We know that the PSP can be further categorized into different subtypes. For example, PSP Richardson type, the most common type, patient would demonstrate early postural instability by keep falling backwards with the impairment of the downward gaze, the eye abnormality. PSP also has the speech variant type, we call primary progressive aphasia type. Patient would demonstrate very distorted and effortful speech pattern. PSP can actually demonstrate cortical basal syndrome type. Patient can have one side of the abnormal movement disorder, including rapid jerky movement like myoclonus or twisting movement we call dystonia. So have you ever wondered whether the apathy level or apathy severity could look different among different subtypes of PSP? And the research from the Mayo Clinic told us that they didn't find any difference between they didn't find any differences in apathy frequency and severity among different PSP subtypes. So equally important. Another important finding in the past few years in movement disorder, in Parkinsonian disorders, is that apathy and impulsivity can actually coexist. You would expect this could be out of expectation, right? Because impulsivity and apathy sounds like two extreme symptoms. But don't forget, they could actually be the result of the frontal lobe dysfunction. So the current research shows that people with PSP, actually 2/3 of the people with PSP can actually have combined apathy and impulsivity. So overall, this study tells us that the apathy and impulsivity should be jointly assessed by clinician when planning symptomatic treatment for detrimental behavioral problems caused by PSP. So how does that look like in CBD? There was a study, neuroimaging study, showing that in people with cortical basal degeneration, if the CBD people demonstrate isolated apathy without other combined features, at the neuroimaging level, they were found to have the posterior parietal atrophy. But for CBD people who have more than apathy, like apathy plus agitation plus depression, they actually have combined frontal and parietal atrophy. So this actually tell us that in CBD people, the parietal lobe actually also plays an important role in apathy. So how do we explain that? Compared to frontal lobe, parietal lobe, the primary function is actually on what we call visual spatial or visual constructional, how we feel ourselves in terms of our relationship with the space, how we see a shape of an object. So overall, parietal lobe is responsible for visual control. And to plan an action, especially a goal-directed action, we actually need to have enough visual control to make it happen. And that's how the authors propose to explain the finding that the parietal lobe plays an important role in CBD people's apathy. So likewise, for cortical basal degeneration, have you ever wondered whether the apathy feature or apathy overall could look like different it could look differently in different kinds of CBD subtypes? So this is a autopsy study from Mayo Clinic Brain Bank. Overall, the researcher found that some people, when they were alive, they were diagnosed with Alzheimer or frontotemporal dementia because they don't really have any motor symptoms. They don't have any movement disorder features. What they demonstrated when they were alive was the pure cognitive dysfunction. However, after they passed away under autopsy, they were actually found to have cortical basal degeneration. So for these 15 people, the researcher categorized them as a cortical basal degeneration cognitive type versus the standard CBD cortical basal syndrome type. And overall, they found that these people actually demonstrate these people with CBD cog type actually demonstrate higher level of the apathy compared to the standard cortical basal syndrome type. And the key finding of this article at the pathology is that people with CBD cognitive type, they actually have more tauopathy. The tau accumulation is actually more in the temporal lobe compared to other lobes. So how does that look like in MSA? This study shows that it's actually pretty common in MSA people to have apathy. The overall neuropsychiatric features in MSA were primarily dominated by depression and apathy. So question that we should think about is that whether the apathy in MSA people could be primarily explained by the frontal lobe. To our understanding, maybe not, because as what we just mentioned, the MSA people tend to have combined cerebellar atrophy. And cerebellum is a brain region that was traditionally taken as a motor function brain region. But in the past 10 to 15 years, it's been increasingly found that cerebellum can actually control non-motor features, including cognitive function and behavioral function. We call cerebellar cognitive affective syndrome. So the dysfunction of the cerebellum can further contribute to the depression and apathy in people with MSA. And overall, MSA people who demonstrate apathy were found to have more severe motor symptoms and longer disease duration. So with that, let's explore the therapeutics of the apathy together. When it comes to treatment, the very first thought that came to our mind might be the medication. So in terms of medication, the first category that demonstrates the effectiveness on treating apathy is actually what we call cholinesterase inhibitor, the standard medication that we treat neurodegeneration dementia, especially Alzheimer. And this category contains three kinds of medication. The generic name is donepezil, rivastigmine, and galantamine. The brand name is probably more well known. The donepezil is called Aricept, and rivastigmine is called Exelon. However, compared to another cognitive medication, which is called Memantine, the Memantine actually doesn't really demonstrate any effect on treating apathy. And interestingly and importantly, the neurostimulants actually demonstrate effect of treating apathy. Let's think about this way. Apathy means lack of motivation, lack of feeling about anything. So the stimulant is actually to boost up the motivation, boost up the awareness. And the neurostimulants contain methylphenidate and modafinil. A physician can consider using methylphenidate or modafinil with or without cholinesterase inhibitor. And of course, if we can put patient on less medication, we would do that. So the third one that shows effect on treating apathy is a medication we call agomelatine. It's actually an atypical antidepressant, different from the traditional antidepressants such as SSRI or SNRI. The chemical structure of the agomelatine is actually pretty similar to melatonin. So it can also be used in treating patients with combined apathy and insomnia. However, until so far, it is still not available in the United States, but could be available in other countries. So many people with atypical Parkinsonian disorders, when apathy was detected, the people with PSP, CBD, or MSA may have already been on so many medication. So is it really consistent with family and patient's goal by taking extra medication? I think there's a lot of room to discuss. So that's why it's also important to explore the non-pharmacological intervention in treating apathy. The current evidence lies on several, including music therapy or music-based intervention, multisensory stimulation that includes massage or aromatherapy, and cognitive stimulation like reading, writing, playing board games, crossword, Sudoku, domino, solitaire for more than 2 hours if possible, and pet therapy. So I want to spend a little bit more time on talking about music therapy because there's an increasing role in music therapy and art therapy in Parkinsonian disorders. If you are interested, you can refer to this article published by Hopkins Group about the review of the music therapy in movement disorders. So what we learned from the Parkinson disease on the music therapy is that overall after music therapy, patients' apathy level actually reduce. So what does music therapy contain? From the published article, it contains facial neck massage, oral movement, and vocalization, followed by rhythmic warm-up, vocal exercise, group singing, and then back to conversation and deep breathing. So of course, I'm not a music therapist, but from a neurologist point of view, by seeing this protocol, it actually comprehensively trained all the orobuccolingual pharyngeal muscles. And Baylor and Vanderbilt, we have a co-project going on now to investigate the role of the art therapy in helping with the quality of life for people with PSP. If you are in Texas or Tennessee, please feel free to reach out if you are interested. So finally, let me talk about a real life example to explore the therapeutic option of the apathy. And this is actually pretty common, basically happening every day in my clinic. So if a family asks you, the doctors say mental and social stimulation is so important, but my loved one isn't interested in doing anything. Why? What could I do to help out? So now we know why. It is most likely apathy. So what could we do in terms of the non-pharmacological intervention? And I'm gonna show two slides, which is courtesy of my colleague, Dr. Mary Keenan. She's a psychologist and counselor in Baylor College of Medicine. And here is her suggestion. We actually print it out as a flyer and hand it to patient and family. So you wanna, as a family member, you wanna consider starting the activity by yourself, model what to do. Then invite people with atypical Parkinsonian disorder to participate. We want to break the activities into small, manageable steps, and then linking the activity maybe with a reward or incentive. For example, after doing this, we're gonna go have a very nice lunch, etc. And we always want to consider gentle phrasing or rephrasing or reprogramming. For example, instead of saying go out to exercise, we want to say we want to go out walk the dog or walk neighbor's dog. Instead of saying exercise, we can consider directly playing the interactive video games that involve body movement. To boost up the exercise level, we can intentionally park a little bit farther when feeding the dogs in the park so that we can incorporate the walking. So let's be creative when thinking about all these non-pharmacological intervention. There's no right or wrong answer. It's all about highly customized to each family. And of course, we learn about the role of the music-based intervention, so we can consider playing music during an activity. And also in the meantime, eliminate unnecessary distractions, such as the background noises from the TV when trying to engage people with apathy. So if you have tried all of this and none of these work, or your loved one's still refusing to engage, what's the next step? Usually we find that officially enroll a person with apathy to a day program could actually be helpful because the day program is stimulating, it's multisensory, and it's actually a social environment because usually you do this with a group. So it's basically a structured program. So the loss of thinking, memory, and motivation won't be too much of the barrier to engagement. And in the day program, there's also a group of professional staff, including trained physical therapists and social workers that can ensure attendees are included. Overall, it can also help with the caregiver because it can alleviate the stress from you. You don't really have the stress that you want to make every activity happen. It can be passed down to the professional staff and the whole day program. And of course, your wellness is important. So always consider enrolling yourself as a caregiver to support group. So with that, I think that conclude my talk today, and thank you for your attention. Here's the picture that we took together in our most recent Center for Care meeting in Philadelphia, and I'm happy to take any question.
Great.
Enrolling your,
Great. Can you hear me, Roy?
yeah, I can hear you.
Great. All right. That was amazing. Thank you so much for kind of clarifying and giving the background on apathy. I feel like that's so important to understand what causes it and why it's a symptom in order to treat it. So thank you so much for that.
Thanks.
The question I have for you is, and you kind of touched on it just now, but I'd love to dive deeper. Let me try to think of how to ask this. I'm curious about your thoughts on help for care partners. Do you have any suggestions on them for when their loved ones are refusing or, excuse me, don't want to partake in activities? Do you have some more treatment suggestions for them?
Mhm. The way I've been using is that we always start with the non-pharmacological intervention first, actually. And after a few months of attempts, it's still not effective, then we'll rediscuss the pros and cons, and also uh, from the viewpoint that whether the apathy really bothers the person or the family's quality of life to eventually decide whether we want to introduce the medication. And for medication, I tend to start with cholinesterase inhibitor because the side effect profile is actually very well known. and easily manageable, as opposed to neurostimulant that sometimes we would have concern about affecting the cardiovascular system. Another reason of prioritizing cholinesterase inhibitor is that people with atypical Parkinsonian disorders a lot of times would have already demonstrated some cognitive impairment or even dementia. So we can sort of like doing one stone, two birds or three birds thing by prescribing cholinesterase inhibitor. And the third one to consider cholinesterase inhibitor first, then the stimulant is that usually the stimulant won't really get covered by insurance. Take modafinil, for example, the insurance usually only cover for people with sleep apnea related fatigue. So sometimes patient would have the access issue. Yeah.
Interesting. Okay. My next question is based on my knowledge that you have an expertise in mood in general. And so I'd love to ask about anxiety and its prevalence in these diseases, as opposed to apathy or compared to.
Right. So thanks for that. That's a very important question. Anecdotally, we usually feel that the anxiety seems more common in people with Parkinson's disease as opposed to atypical Parkinsonian disorders. Uh, People with PSP or atypical Parkinsonian disorders tend to have more apathy, impulsivity, the frontal lobe picture. But of course, anxiety could happen. So when anxiety happens, we can consider a different approach. When it comes to medication, I usually tend to do a more short-acting one, like buspirone, which can be taken up to 3 times daily as needed. And the side effect profile is very well tolerated or don't really, although well documented, don't really show up. But if patient prefers a one tablet once daily thing, then we can consider introducing antidepressant. And it's always important to tell patient and family that although the category belongs to antidepressant, many of them, such as sertraline, can actually treat anxiety effectively, not necessarily to treat depression.
Great, that's a good answer. And then the last question I have for you for now is, can you talk through just a few options like talk therapy and things like that? Just those sort of options that can help with mental health, mood, and mood symptoms.
Sure. This might actually be better answered by psychiatrists, but I'll try my best. So usually for talk, the reason why we would consider referring to psychiatrists to assess the need of including them to talk therapy is that, again, many of the people with atypical Parkinsonian disorders, despite the mood disorder symptoms, including apathy or anxiety or depression, are already high, they actually prefer to not take more medication. And we all know that the power of the mind-body coordination or the information that our brain receives could actually affect the outcomes through clinical practice. And we also know as a physician, just by listening to patient and family, just by this manner, this act, that can actually help address a lot of stress and anxiety. So that's why we usually actively bring the role of the talk therapy or psychotherapy to patient and family. And many of them actually reported to us that they find it very helpful. What I know is that it's kind of logistically, from logistics point of view, it's kind of difficult to do one-to-one talk therapy, but the group therapy were also found very effective, and people actually enjoy it. Yeah, so that would be my answer. But in terms of the detail of the structure of the psychotherapy or talk therapy, I will need to defer to psychologist or psychiatrist.
Makes sense. Sounds like a good pairing too. That's all the questions we have for you today, Dr. Lin. I appreciate you joining us. This was super informative. It's a symptom that can be tricky, and so it's always nice to hear some information on it.
My
Uh,
great pleasure. Thank you for
Yeah.
having me.